proceed.
Okay, thank you. So I said our presentation today, or our meeting, is going to be a short one. And again, I want to thank Radiology Without Borders for giving me this opportunity to present on this platform. So we are going to briefly discuss about early pregnancy failure, especially in sight of ultrasound, what we are going to see on ultrasound, what do we expect to see at what time. So our main objectives for the day, we're going to take a brief look into physiology. What happens after fertilization, the process of cleavage and implantation. This helps us to understand what we should expect at which day of gestational age. We should know what is happening, the physiology behind. The beauty about understanding physiology is you have a better understanding of why you are seeing something or why you're not seeing something. You have a better explanation of why things are appearing the way they are. So we're just going to briefly look at the physiology of fertilization to implantation. We're also going to look at the order of appearing in early pregnancy based on scan, what we expect to see on scan, what follows after what, and things like that. Then we'll go into our main business of the day, that is the signs that we see on ultrasound, the signs for early pregnancy failure. So these are mainly the definitive signs of early pregnancy failure. Someone is switching on their camera and popping up on my screen. Okay, to continue, then we will discuss about what are some features. This we cannot definitely say we have early pregnancy failure, but these features make us to worry that this pregnancy may eventually fail. Then we also have got some less predictive signs. These have got a poor sensitivity and poor specificity, and most of these pregnancies eventually become viable, but some of them, a few of them, eventually miscarry. So to look at what happens after fertilization, I'm sure in the previous lecture or in the previous presentation, we talked about the whole physiology of menstrual cycle, how we get ovulation and all that. So now in this case, as you mentioned earlier, each cycle of ovulation is hoping that they are released, the egg is going to be fertilized. So we're going to look at the events that then happens after fertilization. So after fertilization, the ovary or the oocyte is swept into the fallopian tube. Then if fertilization occurs, mainly occurs when the oocyte is traveling towards the uterus. So it mainly happens in the fallopian tube. We have our fertilization, which is here. Our sperm penetrates into the oocyte and fertilizes the egg. Then we form our zygote. After a few hours, the zygote, the cell division, we get a 2-cell stage. After a few hours, again, we get a 4-cell stage, we get an 8-cell stage, and then eventually we get a 16-cell cell stage, which is now called a morula. This is composed of a zona pellucida, which is this blue line, which we can see covering these cells. So after the morula, these cells continue to divide. They end up at 32-cell stage, and the cells inside begin to release fluid, which forms what we call a blastocyst, which is this fluid cavity seen here. And this cell is now called a blastocyte, a blastocyst. And at this stage, our zona pellucida is still there, is still covering and protecting this cell. Then eventually, the zona pellucida is degenerates, and we get our naked blastocyst. This allows for the cell to then implant into the endometrium. So the endometrium after fertilization, during this process, is called the decidual. Someone once mentioned it in the WhatsApp online platform. So anyway, our blastocyst then is now ready to implant into our decidual. That is our endometrium. So at approximately day 7 after fertilization, which is day 21 after ovulation, the blastocyst then implant into the decidual. That is approximately day 7 and day 8. So the outer layer of the blastocyst, they've got cells, the cells called the trophoblast. So they will invade into the decidual. The microvilli will invade into the endometrium, so that this blastocyst is implanted. Go to the next slide. So this is now our decidual lining. This is the endometrium. This is the decidual lining. So this is our blastocyst cyst, which is implanting into the endometrium. So initially, it has got two cells: the trophoblast and the embryoblast. The embryoblast is the one which will eventually form our embryo or our embryonic disc. Then the trophoblast, we also have got 2 different cells. We have the cytotrophoblast and we have what is called the sphinctotrophoblast. So the sphinctotrophoblast is the one that is responsible for invading the endometrium and will eventually form our placenta. And the rest of the cells are called the cytotrophoblast. So this cytotrophoblast, it plays an important role in the exchange of maternal gas, in the exchange of nutrients, and in different metabolic and immunological functions during early implantation. Then our embryoblast later has got what is called it has got 2 cells, 2 layers of cells. That is the hypoblast, which is this layer at this side, and the epiblast. So the hypoblast consists of cuboidal cells, then the epiblast consists of columnar cells, and this is the part which will eventually form our amniotic cavity as the embryo continues to grow. So these cells, the cytotrophoblast and the sphinctotrophoblast, will pull the blastocyst. As you can see at the beginning of implantation, we have this part of the blastocyst, which is still inside the endometrial cavity. So this will be pulled inside the endometrium so that it's completely embedded into the endometrium, as you can see here. So with time, as the trophoblast is invading into our decidual, it then it is engulfing on the maternal capillary arteries, capillaries, and this is where we get our lacuna, which is responsible for the exchange of the maternal gas, the nutrients during early pregnancy. But most of these, especially up to this stage, we cannot see it on scan. These are just events which are happening in the uterus, but we cannot see anything on scan. We can only see when we now have got our intradecidual cyst time, which we will see as we go on. So we now need to talk about how this normal pregnancy, the order of how things appear, especially looking at ultrasound. So the first sign, okay, at approximately 5 weeks, we expect to see a gestational age. And at approximately 5.5 weeks, we expect to see a yolk sac. Then after 6 weeks, we expect to see an embryo with a cardiac activity, that is the heart motion. So we'll discuss into detail about this statement, which is saying CRO of 5 to 6 millimeters, we should be able to see cardiac activity. And if we have an absent embryo in a gestational sac of 25 millimeters, we then call this an early pregnancy failure. But don't worry about this. We are going to look into detail about it. So the first sign that we see on ultrasound is what we call an intradecidual sign. This is seen at approximately 4.5 weeks. Okay, before I go any further, in the first trimester, it is recommended that we use transvaginal probe, transvaginal scanning, as this is high resolution, and we can only then make a diagnosis of early pregnancy failure when we are using high frequency transvaginal probe, and sometimes in conjunction with beta HCG levels. We cannot, it is not advisable and it is not reliable for us to diagnose early pregnancy failure using a transabdominal probe due to a few reasons, such as the resolution is reduced as the sound beam has to pass through many structures before it reaches the uterus and eventually our gestational sac. We might be dealing with obese patients. So besides the other structures, we have got the adipose tissue which has been added, which will also attenuate our ultrasound beam. So we might actually say we are not seeing the embryo when it is due to our poor resolution, or we might conclude that there is no heartbeat, but it will be due to the poor resolution of the machine and the probe. So it is advisable that in first trimester, as much as possible, if the transvaginal probe is available, try to use a transvaginal probe for better resolution. So you will see that most of these signs that I'm talking about, for example, this intradecidual sign, which is seen at approximately 4.5 weeks, this is seen with high resolution transvaginal probe. On transabdominal probe, we might not be able to see it. So this is seen at approximately 4.5 weeks. It's just seen as a small cystic structure within the endometrium. It's seen in these ultrasound images. So this is just a pictorial for you to appreciate how it looks like. So this is our endometrial cavity. So this is the part of the endometrium where the implantation has taken place. So it is seen as a small cystic structure, as also we can see here. So this is our intradecidual sac sign. So mostly it's eccentric to the central echogenic line. As we are saying, the implantation only happens on one side of the endometrium, either the anterior endometrium or the posterior endometrium. So it's seen eccentric to the central echogenic line, which is where the endometrium cavity collapses, right? And it has got a thin echogenic rim around it, which is the trophoblastic tissue. But however, this is not very accurate. In most cases, you might not be able to see it. So it is helpful if you see it, if present, it is helpful to confirm an intrauterine pregnancy. But if you do not see it, it does not rule out intrauterine pregnancy. And we also have got a few pitfalls when we are looking at intrauterine intradecidual sign, which include just endometrial fluid collection, which might be seen and might be mistaken as an intrauterine pregnancy. Sometimes you also get decidual cysts. But usually, if you then look carefully, these are located at the endometrial myometrial junction. It's not closer to the echogenic line as compared to our intradecidual cyst sac sign. And also, it does not have an echogenic rim. Remember, the echogenic rim is coming from the trophoblastic tissue. So this is not a pregnancy. So we don't have any trophoblastic tissue in this case. So the tecidual cyst, we just see a thin wall for the cyst. There is no echogenic rim around it. And as I mentioned earlier, the intradecidual sac sign is close to the central echogenic line, which is different in a case of a decidual cyst. And if we turn on our color Doppler, we might actually have a little color flash inside, which we do not expect to see in a normal intrauterine pregnancy in the presence of intradecidual cyst. Then from that, at approximately 5 weeks, we see what is called a double decidual sign. This is actually confirms a normal intrauterine pregnancy. It has a high predictive value, positive predictive value. So as we mentioned earlier, a decidual just refers to the endometrium in the first trimester. So what is a double decidual sign is fluid collection which is surrounded by 2 echogenic rings. That's where the double decidual sex sign comes from. So we have our embryo which is implanted here, and we've got our first decidual, which is the decidual capillaris, and capsularis, which is closer to the endometrial cavity. And on the other side, where the embryo is not attached, that decidual is called the decidual parietalis. So we can actually see this fluid, a small amount of fluid in the endometrial cavity. So this endometrium in this case is attached, this embryo, is implanted on the anterior side of the endometrium, and this is our decidual parietalis on the opposite endometrium, where we don't have implantation, where we don't have our chorion. So this is just what is called double decidual sign. It is seen at approximately 5 weeks. Then we also have got a bit of pitfalls also on that. We might get a pseudogestational sac, and how that double decidual sac sign helps us is we don't see this in a pseudogestational sac, because remember, in this the fluid is inside the endometrial cavity. So we only have got we won't be able to see that gestational sac and the little amount of fluid in the endometrial cavity, which gives us the double decidual sac sign. And this fluid is in the endometrium cavity, so it's also not covered by the 2 decidual layers. And what can help us to differentiate it from a normal gestational sac is, normally, as I mentioned earlier, our gestational sac is the shape of it is round to oval. And in a pseudogestational sac, because this is just free fluid collection in the endometrium cavity, it tends to conform to the shape of the endometrium cavity. So we get this teardrop appearance of our fluid collection, as seen in this image. We get this fluid, this teardrop appearance, because this fluid is just conforming to the endometrial cavity. So mostly this occurs in about 10 to 20% of ectopic pregnancies, according to literature. So if you see this sign in someone who's got positive pregnancy test, urine pregnancy test, or the beta HCG, please look around, look in the adnexal regions, and also look in the in the abdomen to look for an ectopic pregnancy. The next sign which we see on ultrasound is what we call a chorionic ring. This is just an echogenic ring around our gestational sac, which is from the chorionic tissue. So it's usually greater than 2 millimeters thick. You also note that when we are now talking about early pregnancy failure, a thin rim has got poor predictive signs. So we have got our echogenic rim, which is greater than 2 millimeters, and this one has got moderate sensitivity, but however, it has high specificity if we see this echogenic rim, this chorionic rim around our gestational sac. And take note that you will also see this same chorionic rim or this echogenic rim around our gestational sac, even in a case of ectopic pregnancy. That's how we then differentiate a corpus luteum from an ectopic pregnancy. Is a corpus luteum doesn't have this echogenic rim, and our pregnancy has got echogenic rim due to the chorion. From approximately 5.5 weeks, Now, inside our gestational sac, we expect to see a yolk sac. And this confirms an intrauterine pregnancy. If we see a sac and we see a yolk sac inside, this confirms an intrauterine pregnancy. Because there are some instances where we can have our gestational sac and eventually the embryo fails to develop, including the yolk sac. So at least if we see a yolk sac inside the gestational sac, it confirms an intrauterine pregnancy. It also rules out a pseudo-gestational sac. You have to take a closer look at your yolk sac. You have to assess the size of the yolk sac. You have to assess the appearance of the yolk sac. We're going to discuss more about that in the coming slides. So, as mentioned here, calcified or thick wad is abnormal. The normal size is approximately 3 to 5 millimeters. It plays a critical role in embryonic development by providing nutrients. If we're looking at twin pregnancy or multiple pregnancies, the number of yolk sacs is equal to the number of amnions. And please take note also on this yolk sac that one embryo is supposed to have one yolk sac. It's not, it's abnormal for us to see one embryo and 2 yolk sacs. So each yolk sac should be associated with one embryo. So that's why when we are dealing with multiple pregnancies early in the first trimester, we can actually count the number of yolk sacs to ascertain the number of embryos. So eventually, as the pregnancy progresses, this yolk sac will become obliterated as the amnion grows and is fused with the chorion. You will see as we go on how the amnion grows and eventually fuses, obliterates this yolk sac. So this is just a pictorial view of the yolk sac and the embryonic development. We are going to talk about the embryo in the next slide. So this is our yolk sac, right? This is our embryo. So from the embryo, that's where we develop our amnion, amniotic membrane or amnion, that eventually gives us the amniotic sac. So this other part from our blastocyst is the chorionic cavity. So with as pregnancy progresses, this amnion eventually expands, and at approximately 8 to 16 weeks, it fuses with the chorionic cavity. So by 16 weeks, it should have fused with the chorionic cavity. That's how also our yolk sac become obliterated. So coming now from our yolk sac, at approximately 6 to 6.5 weeks, our embryo then appears. And it appears as a small little dot, which is seen adjacent to the yolk sac. And this gives rise to what is called the diamond ring sign. So this is actually a positive sign of early embryonic development. And using high resolution transvaginal probe or transvaginal ultrasound, you might actually see a cardiac activity on this small embryo. We can see a flickering sign in this area, in the hyperechoic area. So the size of the diamond, so this is our diamond ring, as you can see from this picture. So the yolk sac is our ring thing. Then the embryo is the diamond. So the diamond size just differs in size depending on the age of our embryo. From a very small dot, from a very small dot, and it can actually grow into a big echogenic mass that you can see adjacent to the uterus, to the yolk sac. From that, remember, let me go back to this picture. Remember, we said after we have our embryo, that's when our amnion begins to form. So this tells us that whenever we see an amnion, it means somewhere we're supposed to see the embryo, because this develops after the develops from and after the embryo. So we'll get to a point at approximately 7 weeks where we get what is called a double blade sign, where we've got our 2 echogenic rings. The first one being the yolk sac, and the second one being the amnion. This is the double bleb sign. So in between the double bleb sign, we should see an embryo, right? Because we say this amnion is developing from the embryo. So as soon as we see, or as long as we see the amnion, we should see an embryo somewhere. So with time, it then develops, the embryo continues to develop. As you can see now at this stage, it's a bit bigger. You can even appreciate where the crumb of the embryo is and the rump. We still have our yolk sac. As time goes on, the amnion continues to expand. We still have our yolk sac. So this is how it eventually then gets obliterated as it is being pushed when the amnion is expanding. You can also see from here, high resolution transvaginal probe, you can appreciate things better. So we are seeing our embryo, we are seeing our amnion, and we are seeing our yolk sac. Please take note that I'm still referring to this as an embryo. We can then call it a fetus after 10 weeks, but before 10 weeks is still called an embryo. So as I mentioned, the amnion is a thin membrane which is surrounding the embryo. It then forms the amniotic cavity where the embryo is inside. The outside part is called the chorionic cavity, where we have our yolk sac. As we can see here, this is the chorionic cavity where we have our yolk sac, and this is the amniotic cavity where we have our embryo. Just to take to mention about this, this that you might come across in early first trimester, which might actually worry you, but it's not something to worry about. We can have this cyst in the fetal head. This is just a normal finding. This is a rhomboencephalon, if we actually expect to see that in a normal pregnancy. So if you see this cyst, don't worry about this, our baby is fine. I mentioned about this, that the amnion continues to expand, the yolk sac is free floating and is now in the chorionic cavity. And as the growth continues, the embryo changes from a dot to a grain of rice and eventually to a kidney shape, where we can actually now see the head and the rump. We can clearly define those. Then let's move on to measurements in early pregnancy. Why this is important is this plays a critical role in diagnosing early pregnancy failure, because we have to know the age of this pregnancy. So we are going to just take a look at what we use to date a pregnancy in the first trimester. So the first tool that we use to measure pregnancy gestational age in first trimester is a gestational sac, where we get the mean sac diameter. That is 3 measurements, and then we get a mean. So the 3 measurements, we are supposed to get the 2 measurements in the longitudinal view and the 3rd measurement in a transverse view. As seen in this picture, this is our longitudinal view, where we take our 2 measurements, and then the transverse view, which we take our 3rd measurement. So we add the 3 measurements together, the length, the height, and the width, and then we divide by 3. Rule of thumb is mean gestational sac plus 30 days is equal to gestational sac in days. The next and the most accurate measurement is the crown rump length. So it is the most accurate, which is used in estimating gestational age, which actually gives us a gestational age which is within the range of 5 to 7 days, plus or minus 5 to 7 days. So this is the preferred method of dating pregnancy. So it is measured between 6 to 13 weeks, and we should measure this in mid-sagittal view through the embryo. I know most of the time we are tempted to measure our crown rump length in coronal views, but coronal view is not accurate. So we really have to be patient, wait for our baby to turn if they are in a coronal view, so that we get the sagittal view and measure our crown rump length. So these are just images showing us how we measure our crown rump length. We can actually even measure it in the first early days when we have our diamond ring sign is indicated on this image. So we're measuring from crown to the rump in a sagittal view, crown to rump in a sagittal view. So we take the longest dimension of the embryo from the head to the bottom, and we should exclude the extremities and make sure also that your embryo should not be flexed. So as I said earlier, just practice patience. Give your baby the time to turn and be in a better position, and you take your measurement so that you get the most accurate crown rump length as you can get. I mentioned this earlier, sorry, my computer is eating up. So I mentioned this earlier about multiple pregnancies. As I said earlier, the number of yolk sacs is equal to the number of embryos. So now in defining the chorionicity, if we see the two yolk sacs in one sac or in one chorion, it means we have got a monochorion, but we've got diamniotic. Because remember, when the embryo is going to develop here, it's going to develop its own amniotic sac. So we're going to, if we have two yolk sacs, we're also going to have two amniotic sacs. So since this is in one chorion, we are going to have a monochorionic diamniotic twin pregnancy. And in a case like this, we've got two different chorions and we've got our two yolk sacs. So we're going to get a dichorionic diamniotic twin pregnancy. Then getting on to our main business of the day, that is ultrasound diagnosis of intrauterine pregnancy, and eventually getting into pregnancy failure. So how we definitely diagnose an intrauterine pregnancy is when we see a yolk sac, as I mentioned earlier, or when we see an embryo. Then there are cases that we might suspect that this is a probable intrauterine pregnancy. We are not definitely sure, but we have signs that are making us suspect that we are moving towards having an intrauterine pregnancy. This includes seeing a minimal amount of fluid or just fluid inside the endometrium cavity or inside the uterus. So according to literature and research and to many researchers, they actually advise that if we see any fluid in the uterus, which is not obviously a pseudosac, remember we talked about how the pseudosac appears, then this is most probably a gestational sac. The other probable cause finding is when we get our intradecidual sign, as we mentioned earlier, our chorionic rim, we talked about it earlier. And we also talked about the pitfalls that you might have decidual cyst, but they are not very common. And they are, so that's why we're saying when we see fluid inside the endometrium, most probably let's take this as a gestational sac, and there's no harm in following up this. So don't just ignore or maybe advise for inappropriate DMC or administration of methotrexate, because we might actually harm a pregnancy which was going to be a normal pregnancy or a viable pregnancy. Then sometimes we cannot see the pregnancy when we have a positive pregnancy test, or we've got our beta HCG levels cutoff value where we are now expecting to see a gestational sac, and we still don't see a gestational sac on ultrasound. This is how we then come to a diagnosis of pregnancy of unknown location. Okay, moving on to failed pregnancy. So we're going to talk about the definitive signs first. And please take note that I actually put this in stars, that we are going to diagnose this using a transvaginal scan of good quality. We also have got some transvaginal scans which are not of good quality. So please take note of your image quality. Take note of all the knobology that you have to play around so that you have the best quality image quality possible for you to diagnose this. So the definitive signs include seeing no heartbeat when our CRL is greater than 7 millimeters. So what we can just do is follow up this pregnancy in approximately 7 to 10 days. If we still don't see a heartbeat, then this is definitely embryonic demise. Whilst we are on this CRL and heartbeat issue, I wanted the case which was approximately 6 weeks and some days, and I got an embryo which I could not see a heartbeat, but the embryo was visible, but there was no heartbeat on B-mode imaging. For some reason, I kept on scanning. Still, I could not see any heartbeat on the embryo. Then I know it is not advisable to use color Doppler, Doppler actually in the first trimester. But because I was now suspecting that this is embryonic demise and I needed to make a diagnosis, I turned on my color Doppler. There was nothing. Now, no color signal from the embryo. For some reason, I don't know why, I kept on scanning. Then I turned color Doppler again. Then at that point, there came just a flash of color signal, and then it would disappear. Came a flash again, disappear, and at that point I was now confused. So what does this mean? Is there a positive heartbeat here or what? Where is this flash coming from? Is it just coming from the sweep of the probe or what? Continue to scan, the patient continued to scan, and eventually at some point when I changed the color Doppler again, there, boom, I see my strong flash of color signal from the embryo. The heartbeat was there. I don't know, up to now, I don't know the physiology of what was happening with that baby. So maybe that's why they recommend that we follow up these pregnancies after 7 to 10 days. But unfortunately for that pregnancy, after about a week, the patient came back. Now this heart signal was there, strong as ever, but it now had subchorionic hematoma. They were threatening his cage. Our heartbeat was still there, strong. Patient was given a rest, but eventually the pregnancy miscarried, so it had a poor prognosis. So I don't know that moment of not having a heartbeat, is it a bad prognostic sign? That's an area of research if there are people who are interested in research. Anyway, moving on, the next most definitive sign is a mean gestational sac of 25 millimeters, and we don't see an embryo inside. So I need you to take note of these definitive signs. How they came up with these cutoff values is they took into consideration intra-observer variability, because initially, back then, they used to take maybe a CRIO of approximately 5 to 6 millimeters, and then they would make a diagnosis that if we don't see heartbeat at this CRL length, then this is an embryonic demise. But as people then took into consideration that there might be mistakes in measurements, and as you know, ultrasound is operator dependent and all that, they noticed that most of some pregnancies which had a chance of being viable were being terminated because of this cutoff value. So they had to take into consideration that intra-observer variability, and then eventually came to a cutoff point of 7 millimeters. And that also, that is also the same issue with the mean sac gestational diameter. At some point, it was actually at 16 millimeters. When research continued, at some point, it was now at 20 millimeters. Then eventually they put it on 25 millimeters. So you will see that with this now, there's a point that will then be sort of in a compromise. We are not sure, because remember, this is a cut-off point. But there are some fetuses that if you don't see the heartbeat at 5 millimeters, actually, literature says whenever you see an embryo, you're supposed to see the heartbeat. So at some point, when we then see our embryo at approximately 5 millimeters and we don't see a heartbeat, this is maybe this is a definite embryonic demise, but we are not yet at our cutoff value. So we cannot definitely make that diagnosis because we haven't reached our cutoff value. So we sort of have a gray zone when we are looking at these cutoff values, because as long as we haven't reached that cutoff value, it's difficult for us to make a definitive diagnosis. But anyway, the advantage is you can then follow up. There is no harm in following up. The harm is actually more when you recommend that they do D&C or give whatever, that pill to evacuate this pregnancy when maybe it had a chance. Delaying management, if it's a case of embryonic demise, with just a week won't do more harm to the patient. So that is the advantage, that we can then, in our gray zones, we can then schedule a follow-up in about a week. And if we see the same result or we don't see the changes, that was the reason in the first in the beginning of the presentations, I had to mention about how this order comes about, how they are, what we expect to see at what age. So if we then schedule a follow-up and there's no change, or we are actually seeing something even worse than what we expected, then we can now make our diagnosis of early pregnancy failure. So whilst we are looking at our definitive diagnostic signs, we have got a few pitfalls. Sometimes the embryo can be at the edge of the yolk sac, and it makes us difficult to appreciate the heartbeat. And you might actually document that there is no heartbeat when it's there because the embryo is close to the edge of the yolk sac. So you need to be careful. You need to really look closer and see if you can, if you are definitely not seeing the heartbeat. So for you to actually come up to a diagnosis of embryonic demise, make sure that your exam itself is adequately enough. Technically, looking at all the controls that are supposed to be adjusted so that we get the best image quality that we can get from that machine. Make sure that all those have been adjusted and you are still not seeing the heartbeat. And also make sure that you have located the embryo certainty. As you can see on the second point, that we might actually get a log below of the gestational sac, which may simulate an embryo. And because this is not an embryo, we are never going to see a heartbeat here. Even if we put on our color Doppler, even if we turn on our M-mode Doppler, even if we adjust zoom or do whatever we want to do, because this is not an embryo, we are not going to see a heartbeat. So before you then conclude that this is embryonic demise, make sure that whatever you're looking at is an embryo. Be 100% sure that whatever you're looking for is an embryo. So search for that embryo thoroughly. Take your time, search for it. After you find the embryo, take your time to search for the heartbeat. Take your time to examine the embryo and make sure that 100% you're not seeing the heartbeat. Then another pitfall also is a chorionic bump, but usually this has got a good outcome. It's not very common, but when it's found, usually it has got a good outcome. And most of the time it is due to hematoma. So if you turn on color Doppler on the chorionic bump, because it's a hematoma, you will not see blood flow. So whenever you see a chorionic bump, please make use of your color Doppler, because in some cases this might be a mass maybe a choriocarcinoma, chorioangioma, or any uterine mass. So turn on your color Doppler and make sure that there's no flow in that chorionic bump. And in cases where we see the chorionic bump and then we don't see any cardiac activity, this makes us worry about embryonic demise. Okay. Then we move on to our what is some signs, the gray zone that I was talking about. So this definitely requires follow-up. But in some cases, it might actually be an embryonic demise, but because we are still in the gray zone, we cannot definitely come up with the diagnosis. So this includes our light sac, which is in the gray zone. As I mentioned earlier, I said back then, before literature was reviewed, early pregnancy failure was actually being diagnosed at a mean sac diameter of 16 millimeters. But because literature was reviewed and they had to put into consideration intra-observer variabilities and mistakes that we make in measurements, that's how we came up with 25 millimeters. So our conflict or confusion then comes when we get a sac between 16 to 24 millimeters and still we don't see an embryo inside, but we haven't reached our cutoff value. So we cannot term this pregnancy early pregnancy failure until we reach our 25 millimeters diameter. But this makes us to worry because usually approximately at around 16 weeks or even 16 millimeters or even earlier, we were supposed to see our embryo inside our gestational sac. So we can then schedule our follow-up to follow up this pregnancy and ascertain viability. Another worrisome feature that you might see is a mean sac diameter is what is called early first trimester oligohydramnios, where when we subtract our CRL from our mean sac diameter, we get a value which is less than 5 millimeters. But according to literature, some of these pregnancies eventually become viable. So it's just a worrisome picture, but some of them eventually miscarry. So we need to follow it up as it increases the risk of pregnancy failure, but it is not reliable. As I mentioned, that some of the pregnancies eventually become viable and become a normal pregnancy. So it is not, it has got very low sensitivity. But the good thing is it is so not common, it's uncommon. So if you, in case, just encounter this, you schedule a follow-up for your pregnancy. Then another worrisome feature is an empty amnion. I think I mentioned it earlier that in an amniotic cavity, we expect to see an embryo inside because this only develops after our embryo is developed. Right? So in between here, we're supposed to see our embryo, as in this case, but we are seeing this big amniotic cavity and there's no embryo. So in most cases, this embryo would have died or resolved and things like that. So this is a worrisome feature for early pregnancy failure, but you can still also just follow it up for approximately, maybe schedule a follow-up after a week. And if you still don't see an embryo in this amniotic cavity, then you can make your definitive diagnosis of early pregnancy failure. We have another worrisome feature, which is bradycardia. So according to literature, when our CRL is less than 5 millimeters and we have got a heartbeat of 80 beats per minute or lower, the chances of survival are very low. We've got actually a less than 1% chance of survival. So most of these pregnancies will eventually miscarry. Then if now the heart rate is between 80 to 89, at least this is a better survival rate, but it's still poor. It's still at 50%. So we've got 50% chance of survival in these pregnancies. When now our CRL is between 5 to 9 millimeters, if our heart rate is around 100 millimeters and below, we also have got a very low survival rate of less than 1%. If it's between 100 to 109, we still have a poor survival rate, but it's better, it's at 50%. So we also need to follow up. So it is actually recommended in cases of bradycardia, it is recommended that you follow it up maybe after 2 to 3 weeks. Give the embryo time to decide what it wants to do with this heart. You can't see this and maybe follow it up after 5 days or 7 days. It's too early. Just give it time. Maybe schedule a follow-up after about 3 weeks and see if we still have bradycardia, or if this heart is eventually decided to behave. So in scheduling for our follow-up, we can use the timing method on how we can schedule our follow-up to then make our definitive diagnosis. So it is expected that when we document, we do a scan and we document a gestational sac without a yolk sac. After approximately 14 days, we should be able to see an embryo inside the gestational sac and an embryo with a heartbeat. If we see a gestational sac and we document a yolk sac, after approximately 11 days, if we do a follow-up, we should be able to see an embryo. So this is what is going to help you in scheduling your follow-up. You are going to look at whether are you seeing a yolk sac or is just a gestational sac. So at approximately after how many days am I expecting to see my embryo? Then you set up the date for scan approximately around those days or even a bit later to give the pregnancy a fighting chance. Whilst we are looking at this thing of gestational sac diameter, remember our cutoff, which I was saying is 25 millimeters. I remember my lecturer, who is Barbara, she once presented on this platform. She was giving us a testimony of one patient that she did, who was actually a relative. And when she scanned, she saw this empty gestational sac, no embryo. Scheduled a follow-up, scanned again, still there was nothing. And this gestational sac had actually, I think she said it had reached the 25 millimeters cutoff. But what she just told the patient is there's no harm in waiting. Eventually, if we are going, if this pregnancy is failed, eventually we are going to have to evacuate this pregnancy. But even if we wait a week more, we can still evacuate it after that 1 week, and it has no harm. Why don't we just give this pregnancy a chance and see? If we still don't see anything after a week, then you can go for evacuation. And I don't know if it was a miracle or what, but that pregnancy actually after one week, when the patient came back, they saw an embryo, and it was actually a normal pregnancy. The pregnancy was carried to term. The baby was born. By the time she gave us that testimony, I think the child was around 6-7 years. So in diagnosing this early pregnancy failure, let's just try to give these pregnancies a fighting chance. We actually do less harm. There's less harm in just giving it a bit more time, in pushing it a bit more than trying to diagnose it early and maybe evacuate a pregnancy which was going to be viable. So maybe just give it a bit of more time. I talked about this. I'm glad I put this in a gray color. So this was our gray zone. So what we call these pregnancies is we don't know the viability of these pregnancies. We have got an intra pregnancy of an uncertain viability. We talked about this earlier. That is our CRA of less than 7 millimeters without a heartbeat. Our mean gestational sac, which is within the gray zone, and we are not seeing an embryo. And not here, we are saying absence of embryo and heart motion 7 to 13 days after a scan showed a GS without a yolk sac. Remember, we said after 14 days, that's when we expect to see an embryo. So we are still within the gray zone. At 7 to 13 days, we are still within the gray zone, which makes it difficult for us then to say this is an early pregnancy failure. So we are still not certain about the viability of this pregnancy. The same happens with when we see a yolk sac. Remember, we said after 11 days, we should be seeing an embryo. So we are still within the gray zone, which makes it difficult to ascertain viability for that pregnancy. Empty amnion sign and enlarged yolk sac. I think at some point in the WhatsApp platform, someone once mentioned about this, the size of the yolk sac, that an enlarged yolk sac has got an increased risk of miscarriage. But what you need to know about risk is it's not every pregnancy or it's not everything that is within the risk group that is going to suffer that. It's just a risk, it just increases the chances. But in some cases, you might not get the risk, you might not be affected by the risk. So in some cases of pregnancies with large yolk sacs, they may miscarry, but we also have got a few that can be lucky and eventually become viable. So that's why we are not certain of the viability of such a pregnancy. We mentioned about oligohydramnios, but we also mentioned that there are some pregnancies, according to literature, which eventually became viable. So we are also not certain about viability. And absence of embryo after 6 weeks. According to literature, after 6 weeks from last menstrual period, on ultrasound scan, on transvaginal ultrasound scan, we are supposed to see an embryo. So if we don't see it after 6 weeks, then we are also not certain about viability. Then just to mention a bit about gestational trophoblastic disease. You would see that I have not talked about ectopic pregnancy and all those other things because I was focusing on a pregnancy which is inside the uterus. So that's why I just had to mention about this gestational trophoblastic disease as it happens inside the uterus. So we've got what we call a complete molar, where we've got our 2 pairs of chromosomes, the 46XX, which are all paternal, and what we then see on ultrasound scan is the echogenic endometrium or placenta with multiple cystic hairs. And when we evaluate the adnexal origins, we'll see thicker luteal cyst in the ovaries. So we've got 23 sperms that fertilizes an empty egg and then duplicate. That's how we get our complete molar. Then in some cases, we get our partial molar. So in this case, we have got triploid chromosomes. So we can have 2 haploid sets, both from paternal. Sometimes we can have 1 haploid set from the mother. So these are the combinations that we can get. We can get 69 chromosomes, XX, XY. So that's 23, 23, 20, 23 X's, 23 X's, and 23Y. And in some cases, we can get 69XXX, and some cases 69XYY. So in conclusion, or what we need to take home is, in a woman who has got a positive pregnancy test, whenever we see fluid in the endometrial cavity, it is statistically likely to be an intrauterine pregnancy. So let's consider this as an intrauterine pregnancy. And we should hold on to all these potentially harmful treatment. They should be avoided at all costs until we have definitely excluded an intrauterine pregnancy, or until we have definitely concluded on an early intrauterine pregnancy failure. So there was this other author who then just took a look at these diagnoses of early pregnancy, and he was just asking, what are the consequences in case we have got a false positive diagnosis of early pregnancy failure or miscarriage? The consequence is we are in doing uterine evacuation when there's a potentially normal intrauterine pregnancy, right? Because we have had a false positive diagnosis of miscarriage or early pregnancy failure. But what about if we have a false negative diagnosis of miscarriage? What are the consequences? We just have delayed intervention for a failed pregnancy failure, but this does not do much harm to the patient. So what would we prefer? Do we prefer the false positives or the false negatives? In my opinion, I would prefer we have the false negatives. And this is how and why we recommend that if you see worrisome features and you're not definitely sure that this is a miscarriage, just schedule a follow-up, because there's minimal harm that you're going to do to this pregnancy and to this patient if you just maybe follow it up after a week, then recommending for this harmful treatment when maybe this was going to be a normal pregnancy. So let's give the pregnancies a fighting chance. Just schedule a follow-up so that you are sure it's not going to do much harm to the patient. With that, I thank you. And I'm handing this over to Miss Christine.
Okay, thank you, Temptations, for the detailed presentation. I'm sure we all learned a lot. I was especially impressed on